Good morning. Coming to you guys today. This is Miss Kofke to talk to you about intravenous therapy. So all of those weeks that you're in clinical and you hear all those letters and numbers pop up whenever you're receiving a report, they're all going to start making sense now. So we're going to talk about why we use IV therapy, what the indications are, what our nursing implications are for our patients that are receiving IV therapy, reasons for different types of IV fluids, and so forth. Okay, so let's start with the purpose of IV fluid. So IV therapy is going to be the most direct absorption, fast action, and as you know, it's going to be the only method of administering medication that's going to lead to 100% bioavailability of whatever you're administering. We use it to replace lost fluids and maintain a normal fluid and electrolyte balance. We'll talk more about those things as we move forward. We will also use the IV route for medication administration, blood transfusions. It can be used for nutritional support if people are not getting their nutritional needs based in by mouth intake. And then it's also used for emergency medications in emergency situations. Different methods of IV administration are going to be primary IV fluid, and we're going to talk about these individually. So no worries there about focusing too much as I'm going through them, because we will talk about each of them individually. So primary IV fluids is going to be the continuous fluids that people are receiving. Secondary IV medications, also referred to as IV piggyback or intermittent medications, IV piggyback medications, are going to be just as they're scheduled. So they won't be continuous, they'll just be given on schedule. IV push medications are also intermittent. So they are not hung up. They're given through a syringe in a push. So IV therapy, as I said, mentioning with primary, secondary, and IV push medications, they can be continuous or intermittent. And your accesses that you'll be using to give IV medications, you'll either have a peripheral IV catheter, so something on the periphery, typically arms. Sometimes you may see them elsewhere. Foot is the most common other place that you'll see them, or a central venous catheter that's going to one of the large veins. And we'll talk more about that, about IV accesses. You'll get more information about that later. So right now we're talking about actually administering the medications. Some disadvantages to IV therapy are going to be infection. So you're going to have a break in skin, which is your big protectant against infections. So any kind of break in the skin is going to leave open a path for pathogens to come in. So infection is going to be one. Fluid overload is going to be a risk with giving continuous IV fluids, and we'll talk more about fluid overload. Also, medication error is going to be more common with IV medications. All the IV medications, after you've pulled them up, they all look the same, right? Almost all of them look like a clear liquid. And so it's easy to get them confused, and they can't be undone quite as easily as a PO medication can be done. It can be, and as we've said, it's going to be your fastest action, 100% bioavailability, and so things can get bad fast. And there's not an easy way to undo what you've done after you've administered an IV medication. It also poses a risk to nurses because there is the risk of blood exposure. So let's talk about some terms that you'll hear whenever you are talking about IV therapy. The first one we're going to say is KVO, or keep vein open. And so that is typically, if you hear somebody say patient has normal saline at KVO, it's meaning that it's going at a very slow rate just to maintain that IV access. It's not a therapeutic amount of fluid going in. It's usually anywhere from 10 to 30 mLs per hour. Drop factor is going to be the number of drops per milliliter. So as you see in your image here, you might have a, your drop factor is going to be shown on your package. So this is a 10, so 10 drops per ml. And that's going to be a macro drop. So a large drop or a large drip. Macro drip or macro drop is going to be large, macro large, micro small. So large drip, macro drip, 10 mLs or 10 drops per ml. And then on your micro drips, it's going to be a lot more drops per ml. So that's going to be a 6. So this one's a 60 micro drip. So there's smaller drops coming out. And the reason you do that is because it's going to be a more precise and more exact method. With the micro drip, it's going to be a more precise and a more exact method of delivering that medication. So what you'll see that with those micro drip or 60 drops per ml IV drip rate or drop factors is going to be with medications that have to be more closely controlled. Like a nitroglycerin drip, you'll see that micro drip used versus whenever you see, what you'll typically see in your medical surgical setting is going to be this macro drop system, just that 10 drops per ml normal rate. So let's talk about IV flow rate. So a lot of our medications, especially IV fluids, are going to be, the IV flow rate is going to be in mLs per hour and milliliters per hour. And that is going to be determined by that drop factor as far as how fast that's going. Remember, if it's 10 drops per ml, then that's going to impact that. But not all medication is going to be delivered in mLs per hour. As we talk through IV therapies, and I'm sure you've heard as we've gone through pharmacology, every medication is different, and you really need to take into consideration the medication specific aspects when you're delivering IV medication. As I said with the previous slide and the drawbacks of IV medication, things can go bad fast. So you really need to triple check yourself and make sure you're doing everything accurately. So it may not be in mLs per hour. Some medications are delivered based on weight. So it may be in micrograms per kilogram per minute. It may be units per hour. It may be drops per minute. There's tons of different ways that medications are going to be administered in the IV setting. So make sure that you know what it is specifically for what you're administering. Okay, your primary IV line set is going to be those continuous. Remember, when we talk about primary, we're talking about a continuous administration. I am going to stop sharing for just a minute and turn my camera back on. So, for instance, if you've got your primary bag that's running continuously, this is going to be your primary IV fluids. They're going to be going continuously. And then if you have a medication order, that's going to be on a secondary line attached to this IV fluid bag. Okay, and I'm going to be talking more about administering and what hangs higher and lower here in a minute, but I wanted to just show you this. So primary bag, continuous, secondary, and that's going to be your primary IV line set. So your primary IV line set is going to be where your primary line is hanging. So those primary IV line sets are going to have your drip chamber, an anti-reflux valve. It's going to have a port here at the top to attach your secondary to. And then as we go on down, it's going to have, and I'm going to go over this again later, it's going to have some sort of a device. The tubing that you're going to be using is going to be put onto a pump. So there's going to be something on all of the tubing that you're using if it's going on a pump and not just going to gravity, and very few places are using gravity these days, that will put it into the pump. So for this particular tubing, it's this little bitty clip. And then as we go down, there will be a roller clip. There will be another access port closer to your patient, and that's where you'll be given IV push medications, is going to be that port closest to your patient. Your secondary IV line set is a lot less complicated. It is going to attach into your primary IV fluid bag. It too is going to have a drip chamber and a roller clamp, but that's it. That's the end of it. Now it's attached to this primary bag. So I'm going to be going over that in a little bit, but it does attach to that closest port to the primary line, and your secondary is going to hang higher. So we'll go more into that here in a little bit. So let me go back to my PowerPoint. Okay. So with your IV fluid administration, you may be giving it as maintenance fluids. So if you've got somebody who is in PO for whatever reason, then you may be giving it just to maintain where they're at. You may also be giving it to replace fluids. So that's going to be your difference. If somebody's not taking in fluid right now and we want them to maintain where they're at, that's going to be that maintenance. If somebody's had nausea, vomiting, diarrhea for the last 3 days and they're dehydrated, then we're replacing fluid. So typical daily intake of water for healthy adults is going to be about 2,300 to 2,900 mLs per day. About 1,200 to 1,500 of that is going to be oral intake of water. The rest is going to come from solid foods and the water that's inside of solid foods. We lose water through our skin, kidneys, lungs, and GI system. Our kidneys being the big one, right? We're getting rid of fluid through the kidneys is going to be the big one. So that replacement is going to be if we're having too much being lost or not enough coming in. All right, so let's talk about specific IV solutions. The abbreviations that you hear with IV fluids, let's talk about what they mean. So we've got, if you hear the letter D, that's going to be dextrose. Let me change colors to something that is easier to see. Red. Okay. So D is going to be dextrose. So anytime you see that D, it means that it is dextrose. W is going to be water. If you hear D5W, that is D5W is dextrose 5% in water. So that's what those letters and numbers mean. The numbers are going to be a percentage of how much of whatever we're talking about is in there. So D dextrose, 5 is the number, so percentage, 5% dextrose in water. Other things you'll hear is normal saline, saline, or you may just hear saline. A lot of times that normal is kind of kicked off by the nurses. So what you'll hear is saline, and that's going to be normal saline. Normal saline, without saying the percent, we don't typically just say the percentage because it's just, you'll get to know it and love it. Normal saline is 0.9% sodium chloride. And as you know, sodium chloride is salt. So normal saline solution is going to be 0.9% sodium chloride. So 0.9% salt in the water. So another one that you hear is half normal saline. So if it's half normal saline, then it's half of this percentage. So half normal saline is going to be 0.45% sodium chloride. So half normal saline, half the percentage. So normal saline 0.9%, half normal saline 0.45%. We're going to talk about what these different things mean in just a few minutes. We'll go through the different types of IV fluids. So next up, LR. And we'll talk about what is in that here in a minute, but LR stands for lactated ringers. So you've got all these different letter abbreviations that you do need to be familiar with. So if you had somebody who, let me move my coffee cup so I can see on my screen here. Okay, so if you had somebody who was on D5LR, that would be dextrose 5% in lactated ringers. If you had somebody that had, actually, let me just turn my camera off and I'll show you this bag that I'm holding. Actually, let me do this. I'll go ahead and write it on here. D5 half normal saline is what you got in report. Patients on D5.5. And they might not even say normal saline. If you get in report, what you're going to hear is patients on D5.5 at 75. So that is going to be D5.5 normal saline. So let me turn my camera back on real quick and stop my share just for a second. So this bag I have here is that D5.5. So it's dextrose 5% in half normal saline. So it's dextrose 5% and 0.45% sodium chloride. And then this little bag I have here is normal saline, that 0.9% sodium chloride. I think it's backwards whenever I'm holding it up for you. All right. Let me share again. All right. So let's talk about all those different types of fluids and why we use different ones. When we talk about osmolarity or osmolality, we're talking about the percentage or the number of dissolved particles contained in that unit of fluid. So the difference in osmolality and osmolarity is really going to be the unit we're using. With osmolality, it's kilograms, and with osmolarity, it's in liters. So we're not going to tear apart the difference in those two right now. That's beyond where we're going to go right now. So for our purposes, osmolarity and osmolality is basically, we're talking about what is the concentration of the fluid. It refers to the number of particles dissolved in serum. Primarily looking at sodium, urea, and so think about your blood urea nitrogen levels, and glucose is typically what we're going to be looking at. So your normal serum osmolality is around 300. So that's what is just the normal concentration in your blood at any given time. And that could go up or down depending on what type of a disease process you have going on. And that serum osmolality, based on whatever's going on with your client, is going to help the healthcare provider determine which type of IV fluid is going to be most helpful for your client. So that's when we talk about the tonicity of the fluid. And I'm going to talk about each of these separately going forward. So I'm not going to dig too deep in them right now, but that's what we're talking about with hypertonic, hypotonic, and isotonic, is that osmolality. And how is that going to affect the cells in the serum? Another term that we use when we talk about IV therapy is colloids and crystalloids. So colloid solutions are going to contain proteins or other large molecular substances that will increase the osmolarity without dissolving in the solution, because their particles are large and they're unable to pass through the semi-permeable membranes of the capillary walls. They stay inside the vasculature and they are known as plasma expanders. So colloids are used, they will pull fluid from the interstitial space into the plasma and increase blood volume. And so that's colloids, larger particles and proteins that we can use. And they, as I said, they're known as plasma expanders because they can't cross that capillary membrane, that semi-permeable membrane of the capillary walls. So the colloids stay in the vasculature and will help pull fluid in as well. And so they will increase blood volume. We're not going to talk a whole lot about the colloids right now. We're going to focus on crystalloids today. So crystalloid solutions contain fluid and electrolytes. So they are able to move freely across those capillary walls. They don't contain proteins or any of those large particles. And they can cause plasma expansion or increasing that blood volume, but it's going to have a lot shorter duration than those colloids do, because those colloids are going to stay inside the system, inside the vasculature. They're too big to go elsewhere. So that's why they're going to expand the blood. And the crystalloids, they will expand, but then they are also can go through that semi-permeable membrane of the capillaries. So let's talk about all these specific, these three specific types of fluid with the tonicity: the isotonic, hypotonic, and hypertonic. When we talk about each of these, with the hypertonic, hypotonic, and isotonic, we're looking at their osmolality. So water is going to follow salt. So with a hypertonic solution, that means the tonicity or the osmolality of that solution is higher than in the serum or in the blood. So what you will see is the cells, pencil, is the cells with hypertonic solutions. The water inside of the cells will come out. It's going to come out of the cells because there's more salt here on the outside than on the inside of the cell. So inside of the plasma, water is going to leave the cells. With hypotonic, we're going to have the opposite. It's going to have a lower osmolality than serum. So if it has a lower osmolality than serum, it has less, it's more water, less concentrate. So this water is going to go into the cells because there's a higher concentration of salt inside the cell. So water is going to go into the cells and create this big bloated cell. He looks kind of sad. This guy looks kind of mad because all his water left. This guy's So he's all dehydrated. This guy's all overinflated. And then over here, we've got our isotonic fellow. So over here, our isotonic solutions are going to have the same osmolality about as serum does. So water's flowing freely in, freely out, maintaining your normal cellular composition. So he's just kind of chilling. So there's going to be different indications for each of these. So we're going to look at them individually now. First up, we have isotonic solutions. As I said, water is going to be able to move freely in and freely out of the cells and maintain a normal intracellular hydration. So these are going to have about the same, isotonic solutions are going to have about the same osmolality as your serum level, as serum does. So indications for isotonic solutions are going to be for hydration, so to replace fluid loss. It can correct dehydration. It's going to be used for sodium depletion. Remember, normal saline is 0.9% sodium chloride. So if you have low sodium levels, it could be used to replace some sodium. Also, it's going to be used to just replace excessive losses through nausea, vomiting, dehydration, blood loss. It's going to be a quick replacement if somebody's bleeding out. It's going to be a quick volume replacer. It can help to provide some calories if you're using dextrose. So let's talk about the different types of isotonic solutions. So first up, I've already mentioned normal saline is one of your big ones here. So normal saline is going to be an isotonic solution. It's just going to be that salt water. So fluid replacement. That's all you're getting with sodium, with normal saline, is some sodium replacement, and then also just fluid replacement. Another one is going to be LR, or lactated ringers. And we're starting to see that LR used a lot more frequently. So LR contains some electrolytes. So it's going to be used for rehydration in all types of dehydration and fluid volume deficit. It should be used cautiously in patients with renal failure because it does have potassium in it. And remember, if your kidneys aren't working, you're not getting rid of potassium. So then you could run into problems with having an elevated potassium level if using LR with patients with renal failure. It also should be used with caution in patients with liver disease because the liver can convert that LR it converts it to bicarbonate. So if there's problems in the liver, it may mess with that conversion process. So LR is going to be used to replace some electrolytes too. So that may be what you see if somebody has been nausea, vomiting, diarrhea also, because they may have lost some electrolytes with that disease process also. Next up is dextrose. So the D5W, dextrose 5% in water, is going to be isotonic, and it, you may see it does provide some calories with that dextrose. So that may be why it is being used. So some things to consider as a nurse administering these medications is use isotonic fluids with caution in patients with cardiac and renal disease because they're going to be at risk of fluid volume excess and being overloaded. So think about, how do you know if that's happening? How do you know if your patient is becoming overloaded and has fluid volume excess? systemic things like edema, and then also pulmonary edema and fluid in the lungs. So your patient gets suddenly short of breath and you hear crackles and they're receiving IV fluids, they have cardiac or renal disease. That's what you want to look at being the cause, is IV fluid and fluid volume overload. So in any cardiac or renal patients, we're going to be on the lookout for fluid volume overload, pulmonary or systemically. Hypotonic solutions are going to have a lower osmolality. So hypo, low osmolality. So fluid, is going to be moving inside the cells. Water is going to move into the red blood cells. Let me get my pencil going. So water is going to be moving inside because it's going to have a higher oh, let me get a different color. Okay. It's going to have a higher concentration of particles inside the cell. So water is going to follow that and go into the cells. So what can happen then is as that water moves into the cells, those cells will swell. But if you overdo it, then it can cause those red blood cells to burst if they get overhydrated. So let's talk about what we're going to use these fluids for. So as we said, water's going into the cell. So we're going to use it to replace cellular fluid in states where we see intracellular dehydration. So we see intracellular dehydration and DKA, or diabetic ketoacidosis. So you'll see hypotonic solutions used in this case. And then also in hyperosmolar, hyperglycemic state. So if you've got a hyperosmolar state, so the osmolarity or osmolality is increased, then giving a hypotonic solution is going to make that a little bit more level playing field. So if you've got a hyperosmolic state, that means the osmolarity or osmolality of the blood is elevated. That would have caused those red blood cells to shrink. So we're going to go back and do the opposite and give a hypotonic solution to rehydrate those red blood cells. It also helps provide free water to allow excretion of body waste. And then if you're giving it, if you're doing it with dextrose, it could provide some calories as well. That said, most of the fluids that you see given as a hypotonic solution is going to be sodium chloride solutions. So the big one you're going to see is that half normal saline. So remember, normal saline was isotonic. So if you've got half as much sodium chloride, it's going to be hypotonic. It's going to have less concentration of sodium chloride. So if it's got it's going to have half as much concentration of sodium chloride. So it's going to be hypotonic. And that's at 0.45%. Sodium chloride. And then your other solutions are going to be anything less than that. So any salt solutions less than that 0.5%. So you may see 0.33 or 0.25, but any of those that are less than the normal saline are going to be hypotonic. So nursing considerations. You would not use hypotonic solutions in patients with known or suspected increases in intracranial pressure, patients with liver disease who are in shock, have experienced trauma or burns, because it can deplete that intravascular volume. And so we're not going to use it in people who need more volume in that vasculature, because that serum, in your serum, this is your blood vessel, and you've got your fluid, and then you've got your red blood cells. If you're administering a hypotonic solution, that fluid's going into the cells, into the red blood cells, so it's not maintaining all that fluid in the vasculature. So it can put you at risk for fluid volume deficit. So that's going to be why you would not administer it to somebody in shock or with burns, because we want to increase that intravascular volume. This intravascular volume wants to be increased then, but it's going to be decreased if all that fluid's going into the red blood cells. So that's going to be the thing that we're going to be monitoring for, is that fluid volume deficit. And typically hypotonic solutions are not used long-term. They're used short-term to treat whatever has led to the intracellular dehydration. All right, next step we have, and lastly, hypertonic solutions. So hypertonic, the sodium content, let me get my pencil out again. Your sodium content is going to be higher outside of the red blood cells. So it is got higher tonicity, hypertonic, higher tonicity, higher osmolarity or osmolality outside of the cell. So water is going to be leaving the cells and going into the vasculature. So you're going to see these red blood cells shrinking. So indications for use of a hypertonic solution is going to be to correct severe hyponatremia. So if you have severe low sodium levels, we'll use it to increase the sodium levels. It also can help to decrease intracranial pressure in patients with cerebral edema. If it has dextrose in it, we can use it to provide some calories. We want to use it, let me go ahead and go over some examples real quick before we go over those nursing implications. So examples. So just like with the hypotonic, where if it had lower salt content, it was hypotonic, you're going to see the same of that with hypertonic. So if you remember the isotonic ones, then you can kind of go off of that to see where they lay on the spectrum. So anything with a higher concentration than the isotonic solutions. So that D5.5 normal saline. So if dextrose 5% is isotonic, adding anything to that is going to make it hypertonic. So that half normal saline added to it is going to shift it to hypertonic. Same if you see D5 normal saline, D5 is isotonic, so anything added to it is going to be high, it's going to add to that concentration, it's going to make it hypertonic. So D5.5, D5 normal saline, D10, 10% dextrose in water, or 3% normal saline. 3%, that wasn't a very good percentage line, sorry. 3% normal saline is going to also be, because it is higher in concentration than that normal saline. If it's over your, if it's got anything added over your isotonic solutions, that's going to push it into that hypertonic area. So we want to, for nursing implications, we want to use caution because it can cause intravascular fluid volume overload. Just like with the hypotonic, you were at risk for fluid volume deficit because fluid was going into the red blood cells. Now all the fluid's coming out of the red blood cells and into the vasculature. So you're going to be at risk for fluid volume overload and pulmonary edema. So these will be used in a slow administration and with an infusion pump and constant monitoring for signs and symptoms of fluid volume excess. Again, just like with the hypotonic, they're not going to typically be used for a prolonged amount of time. And they are going to be contraindicated for patients with cardiac or renal disease because of that risk of fluid volume overload. Anything with the high concentration of dextrose, if it's greater than 10% dextrose, it needs to be given through a central line. Okay, so let's talk about administration of IV medications and fluids. So what you see a lot on a medical surgical floor is going to be a saline lock catheter. So whenever you're doing any kind of IV medication, we want to make sure that you're doing vigorous hand washing, that you're cleaning your hands before and after, wearing the proper PPE, and cleaning that site appropriately. So when you see your patient's IV site, we're going to talk more about assessing it here in a little while. But this is a good, normal, clean dressing here. And we'll talk about what these colors mean here in a little bit and how to know what size of an IV you're using. So we're going to assess our peripheral IV sites every 1 to 2 hours if somebody is receiving continuous IV therapy, including just an isotonic solution. We want to monitor it closely for complications, which we will talk about in just a little while. If that peripheral IV does not have IV fluids running, you still want to check it every at least every shift and monitor that site. So we'll talk more about what that means here in a little bit. PPE wise, you'll wear whatever you are needing to wear for whatever that your patient's disease process is, but then also wearing gloves as well. Before administering any medication through an IV, you're going to aspirate for blood return, and we'll go through this process here in just a minute. You've got your primary line we talked about earlier. That's with your continuous fluids. Secondary line with your IV piggybacks. And then your other way of giving medications is going to be through that IV push or through a syringe that you push through. So let's go through talking about the process of administering medications through an IV. So as we said, medications may be given IV push, as a primary IV fluid, which is continuous, or as a secondary IV piggyback, which is going to be intermittent. So the first step for any time that you're administering any IV medications is to determine the rate of infusion. So that's going to still be for if it's push, primary, or secondary. So an IV push medication, you'll administer over a certain amount of time, and that's going to be medication specific. There is no rule for all of the medication types, because some medications you might have to push IV push over 5+ minutes. Some of them you may push very rapidly because they get metabolized out really fast. So it's really medication specific as far as the rate. And that's going to be for all of it. So for IV push, determine your rate. Primary IV fluids are going to have an ordered rate with them. And then secondary IV piggybacks and these intermittent medications are also going to have, they're going to be medication specific. Some, and you know, I always think about antibiotics. I think that's in this unit also. And some antibiotics run over 30 minutes. Some antibiotics run over 4 hours. So it's important to determine the correct rate for that specific medication. The next thing we want to look at is what type of an access does this client have? So for example, if it's a peripheral IV site, you can only run one medication at a time through that line a lot of times. Usually it depends on the compatibility, which is our next step. We'll talk about in just a second. Where if you have a PICC line or a peripherally inserted central catheter that's going into one of those large veins, you may have 2 or 3 ports going to it. And if you do, then you could run multiple things all at the same time. Also, some medications, you'll see when we talk about potassium, your rate, some things you could run faster if it's in a central catheter, but if it's in a peripheral IV catheter, then it has to run slower. So you'll see that also. The next thing is going to be to determine the compatibility. So compatibility is going to be, is that can the 2 medications run together, or is it, or can you give whatever secondary piggyback medication you're giving with your primary IV fluid? Because remember, primary IV fluid, your primary fluid may not just be normal saline or D5W. It may be a heparin drip. Because remember, primary means that it's continuous. So that may be a heparin drip. That may be a cardizem drip. That may be some other type of a drip. So you're going to need to know, can I run these things together? So determining the compatibility is going to be very important. It may be needing to be given, you may have to start a second IV to be able to give an IV piggyback if you've got something like heparin running that can't be stopped and it's not compatible with it. But even normal saline and dextrose are going to have, there's going to be medications and antibiotics and things that are not compatible with them. So you still have to check compatibility with your medication. And then our last step here is going to be inspecting the site and making sure that the site looks good. And we'll talk about what it looks like if it doesn't look good here in just a little bit. So just to make sure that you, if you're administering any medications, that you read the instructions and look up specific medication information in the drug book to determine how to prepare and how to administer the medication. Excuse me, because as I said, they are all going to be different. For example, Protonix, if you are given Protonix IV to your patient, it's going to be, you're going to get it out of the Pyxis or whatever the med dispense system is, typically in a powder form. And you'll have to mix it with 10 mLs of normal saline. And then you'll flush the IV site with 10 mLs of normal saline before and after. And then Protonix is given over 2 minutes. But that's not going to be the same for other medications. So just making sure that you're medication specific and looking at what is specific to that medication. So hang time is going to refer to how long you can leave IV tubing or IV fluids hanging up at the patient's bedside. So the Infusion Nurses Society give us guidelines to go off of. But that's also going to be facility dependent. You may not see this being used in your facility. So always follow facility guidelines. But our typical guidelines from the Infusion Nurses Society is going to be for a continuous IV fluid solution. those sets can go for 96 hours. If it is a intermittent infusion, so if you have somebody who has is just getting their antibiotics and they're not getting regular IV fluids all the time, but you're only hooking them up and giving the IV fluid and then removing or giving their piggyback and then taking them off the administration set, those should only be those should be changed every 24 hours. So the difference in that, remember our big risk factor of introducing infection and pathogens into the bloodstream. If you're connecting, disconnecting, connecting, disconnecting multiple times a day, these intermittent sets are you're gonna have a higher chance of those getting infected versus a continuous infusion where you're just hooking it up and it's going and not being disconnected and reconnected all the time. Blood and blood components are single use. You only use those tubings one time and they are for a 4-hour max. If you are giving lipids or fat emulsions as well as parenteral nutrition, these are going to need to be changed every 24 hours. A lot of places you'll see that the lipids are every 12 hours, but that's going to be a facility specific thing. And the reason for that is that they've got so much in them that bacteria loves, and they're just hotbeds for bacteria to grow in. Let me erase my stuff. Okay. So when you are giving IV medications that are hung up, they may be in glass bottles or they may be in plastic bags. A lot of our IV fluids we see in plastic bags, but you may also see glass bottles. I was seeing if I had a vent. I don't on my tubing that I have here, but what you'll see with glass bottles, because of the pressure, let me start my video real quick. So with this bag, as it pulls the fluid out, this bag's going to shrink, right? It's going to be able to shrink. Glass bottles obviously can't shrink. If you've got this in there and you're pulling out fluid, it's got a specific volume in that glass bottle and it's not going to be able to pull out. So what you'll see is down here on this drip chamber, there's like a little door that you open up on tubings, on vented tubing. So if you're using glass bottles, you have to use a vented tubing, and it has a little door right here that you open up. And then plastic, it's not required. So if you need to write on your bag, don't write with a marker, put it on a sticker and stick it on there. Always label everything. Label, label, label. I think we talked about this in safe medication administration. I told you guys about the nurse that used the unlabeled bag and administered the potassium, and the patient didn't make it. So where that potassium had already been added. So always, always, always label your bags if you've added anything to them. All right, so your primary IV line, we talked about this. It has your, you may have an injection port in that primary IV bag. Let me just start my video again real quick. So with these bags of fluid, this port at the bottom here, you've got these two things at the bottom. One has a little tab you pull off to put in your drip chamber to put your primary line into. This other is a injection port. It's where you could add medications to this bag if you needed to with a needle. So that, and then some bags you'll see them here on the side like this. We've got your drip chamber so that you can see that medication being dripped in, injection ports, and roller clamps. And then most of them also have these slide clamps. Okay, so you also have your secondary line. As I said, it has your drip chamber. Oh, this picture, this one, this is that little door that I was talking about. If you have a glass bottle, this one has that little door that you could open to vent your tubing. So the secondary lines are less complicated. They've got the drip chamber. This one has a injection port, but most secondary lines do not have this injection port. And they'll just connect right to the primary line here. They connect closest, your secondary line, you will connect at that closest injection port to the primary fluid. Closest injection port to it. It needs to be above the pump. You will put it above the pump because you want it pulling from this bag if you're using that secondary line. They also come with this hangy thing that you would attach to your primary line. Comes with your secondary line. Your secondary line, though, is going to hang higher because that's the way gravity works. Whatever you want to run needs to be higher. So if you're running a secondary piggyback line, it needs to be higher than the primary line. So you'll use that hanger to drop down the primary fluid so that you can put the secondary up higher. And I'm getting ready to show a video and go through this process for you in just a second. Okay, so, and then IV push. As I said, with IV push medication, please be careful because if you inject something too fast that does not need to be given fast, you will kill your patient. So please, please, please make sure that you are being medication specific and looking up how that medication is ordered to be given. So IV push medication, vigorously clean the hub, flush before and after, check compatibility. So we have kind of looked at these. I'm going to play a video of going through the motions of priming a primary IV line and secondary, hanging up a secondary and giving an IV push medication. Okay, so now let's go through the motions of hanging up those primary IV fluids, secondary fluids, and giving an IV push medication. Again, this is just going to be a general muscle memory, going through the motions of the process of it. Not going through all the safeguards you would have medication specific. But remember, anytime that you're administering any medication, including IV fluids, understand the implication, understand why they're getting it, know what the compatibility is if you're giving a primary and a secondary together, know if they can mix together, go through all those patient rights checks and all those things that you would do. Assess your IV site, make sure it's patent. But we're just going to talk basically about how to prime the tubing and get it started, how to administer the secondary medication, and same with the IV push. Okay, so first up, let's talk about the primary IV fluid. So right now we're going to go with that we're going to be giving. We're going to, like we always do, check that we have the right solution. Today we're going to be giving D5.5. So that is what we've got here. We are going to hang it up so that we can get it started. We need our primary IV line, our primary IV tubing. Okay, and so I've got that here. So again, we're going to maintain aseptic technique for everything we do. First up, we're going to clamp off this tubing before we spike it. We're going to clamp it. It makes everything easier. It makes it easier to get the bubbles out. Okay, so we have
we're going to be maintaining aseptic technique and keeping the tips of everything clean. We're going to pull this plug on here. Some of them are harder than others. And then, so this is sterile right now underneath here, so we don't want to touch it. We're going to pull the end off of our primary tubing. Again, this tip is clean, it's sterile. So not just clean, but sterile clean. So now we're not going to touch them to anything else except for each other. So just carefully, I'm going to try to turn it so you can see, carefully going in through here, and then just twist it to gain access there. Some of them, it is like, takes them back, takes some extra strength to get it in there. Okay, so next up, we've got our drip chamber. So we are going to squeeze that till it is just about half full. It is not like 2/3 to a half full or 1/3 to a half full. There's not a magic place where it has to be at, just around halfway. That's going to tell us where we can see. We don't want it full, okay? Because if it's all the way full, would I be able to tell if this was dripping or not? No, I wouldn't. So now what am I going to do? Easy peasy. These things work great. So if your drip chamber, if you do accidentally squeeze too much in your drip chamber, you want to be able to see it dripping. So this isn't going to work. But all you got to do is take it, flip it upside down, and squeeze that air, squeeze some of that back into this bag. Okay? So now we're back to about halfway. I'm going to have a little bit less. Okay. All right. So now I've got my drip chamber back how I want it to be. So don't freak out about it. If pretty much, as long as you don't contaminate the line, pretty much anything else can be dealt with as far as when you're starting your IV fluids. But so don't panic if you do something wrong. We can fix it. Okay, so now what we're going to do is get the air out of the line. So we're going to open up our line and watch the fluid fill up until it's going to go slow because I'm holding it up high. Remember, this is working by gravity. So if I'm holding it up higher than my line, it's not going to want to drip. As soon as I dropped it down low, you might see the drip chamber. As soon as I held it down low, it quickly released. So now I've got my line all the way cleared. Okay, so if I'm going to start this on my patient, I'm going to just turn you towards my patient for real quick. Okay, so as we said, if we're going to start some fluids, we want to scrub this hub. This thing has been laying there. This patient got his breakfast all over it and everything else. Been sitting up against his bed, getting all sorts of normal flora, bacteria growing all over it. So we're going to clean it really, really good. 15 seconds scrubbing the hub. Again, maintaining aseptic technique. So I'm trying to turn this so that you can see my hands, the way you do this with just your two hands. So I've got 2 fingers holding this hub so it doesn't fall down and get dirty again, right? I'm holding that. So then with the rest of my hand, I'm going to use my pinky and twist off this cap without contaminating this tip. You know, you were going to be using every single finger for different things. And then just like we did up there, we're going to make sure that we connect them without touching anything else. And now it's connected. So always before you connect, make sure you've already, as I said, we're just going to go into the motions. But remember, always flush your IV before starting your IV fluids. Make sure that it is, everything is working good and you don't have any kind of alterations in function of that IV, making sure that it's good and clean and dry and functioning good. So always flushing ahead of time. So, but like I said, we're just going through the actual process of doing it, of what you do to spike the bag and get the fluid through it. Okay, so now let's look at if we're going to give a secondary medication through our primary line. All right, get your supplies together. Things we're going to need is your secondary medication, whatever it is. secondary IV tubing and this little hangy thing. I'm sure it's got an actual name. So let's talk about the difference in secondary IV tubing and primary IV tubing. First of all, the length, right? This is pretty short, so like 30 feet long maybe. The other thing that you'll notice, it does have a roller clamp on it, just like your primary does. But your primary line has a valve here. It has injection ports here, and then again down close to our patient, we have another injection port. So that's going to be the difference there. And then depending on what type of a pump you are using, you'll have usually some different type of a mechanism on the primary line that makes it compatible with that pump. For this one, it's this little blue slide clamp. It works, it goes in here. I'm not going to put it in there because it's just loud. And sometimes it doesn't want to stop screaming. So we're going to look at doing this secondary tubing. Okay, so first thing that we're going to do is clamp it. Okay. The next thing, if it is clamped, you can go ahead and do the same as we did with our primary as far as keeping everything clean, but we got it in our hand. Pull it out. Keep everything clean. Using my pinky again and pulling that piece out. Aseptic technique to push this in. Okay, so could I prime this the same way I did the primary line? Squeeze some fluid into the strip chamber and then run it out till I don't see any air. I could, but what's going to happen is whenever you run out of fluid to clear like you do your primary line, you lose some fluid because you're going to be running those bubbles out. So you're going to lose some volume. And remember, this is our medication. This is a medication, an antibiotic, whatever it is that your patient needs to get all of it. We don't want to just administer what was left after we got rid of the bubbles. We want every last bit of this to get into our patient. So what we are going to do is we're going to leave it unprimed for just a minute, okay? I'm going to hang it up. So now comes into play my little hangy thing. So I'm going to connect my primary tubing to the bottom of this hook and hang it up, okay? So remember, just like we talked about with the water, with the air getting out of the line, primary versus secondary is also going to work on the principle of gravity. Whatever is higher is what is going to go in. We want this medication is what we want to be administered. We want it to be what goes in. So to be able to get that to happen, we need it above the primary line. If it is below the primary line is what's going to run. Okay, so we are going to connect the secondary line to the port closest to the IV bag, okay? The secondary line goes closest to the IV bag. We're going to do the same thing we did before. We're going to scrub our hub. Aseptically connect these lines. All right. So we are now going to back flush this line. I'm going to just lower this down a little bit so I can show you something real quick. Okay, on this IV line here, on our primary line, we have here an anti-reflux valve. That means that fluid can go out of that primary line, but it can't flow into that primary line. You'll see on our secondary line, we have no such anti-reflux valve. What we're going to do is we're going to prime up this line to get the air out of it. but maintain the medication and not lose anything in the process. So what we're going to do, I'm going to try to get this closer so you can see. Okay, I'm going to open up this clamp that's on the secondary tubing. If I lower it below my primary IV, you'll see that primary IV start to drip, okay? You see air bubbles starting, I'm gonna lower this a little bit more. Air bubbles starting to come into my secondary line, right? The lower you take it, the faster it's gonna fill up because that's the way gravity works. So we're gonna do that until we get our drip chamber about halfway full. So just because, so you can hang that down real low. I'm gonna actually, it's taking a long time. But so that won't go backwards. If I hold this up higher, it's not gonna backflow into that primary bag because of the anti-reflux now. So I'm gonna hold this up higher so that I can get it to go in. Okay, so I now have, I'm gonna hang this back up high. I hang this down low. So I now have my drip chamber on my secondary line about half done. Okay? So that way we know that we got the air out, but we didn't compromise our volume from our bag or lose anything in the process. Okay. So let's see here. Other things that we want to look at, it's going to be when we administer this, and we'll program it into our IV pump. Most IV pumps are going to prompt you and say, make sure that this is unclamped. Made a little bit of mess. Make sure that this is unclamped. There's been a ton of cases, I've seen it multiple times myself, where nurses hang up this secondary bag, but they leave this line clamped. So if this line is clamped and you're running your bag, it's going to run out of the primary bag, not out of your secondary bag. So it might be the next person going to give the antibiotics. They go to hang up the next dose of the antibiotic, and the dose before it is still hanging there. So that can be detrimental to your patient's health, right? So we're going to not do that. We're going to make sure that we unclamp this. Always visualize it. Whatever you want to be dripping, before you walk out of your patient's room, you should eyeball that and make sure that that is what is dripping at that time. Okay, so let's move on to IV push medication. Again, not going through all the safeguards you go through with all your medication. Make sure you're being specific to your client and to your medication. I'm just going through the process here of how to administer. So first up, we've got our medication we're going to give. Things that we need a syringe, an appropriate size syringe. I'm going to be giving 3 mLs, and I've got a 5 ml syringe. So I could use a 3, a 5, a 2 to be able to do that. We need a micro pen to be able to stick into our vial here. The first step we'll do is get our medication ready. We're going to scrub this hub. We'll scrub all the other hubs. We're going to scrub the top. Now, this has already been opened, so it doesn't have that plastic cap on top. Even if it has that plastic cap on top, still clean it. Really good on top. We're going to let that dry. Meanwhile, I'm going to go ahead and get my syringe ready. Micro pen came out of a sterile package. I'm going to keep that end of it sterile. That's going to connect to my syringe. My syringe, same thing, coming out of a sterile package. I'm going to keep that end of it sterile. Connect those two together. Okay. So if you're using a multi-dose vial, just like with your sub-Q and your IM, if you're using a multi-dose vial, you can push it in, push air in. If you're not using a multi-dose vial, you can just pull out what you need. Sometimes you're given the whole syringe. So I'm going to give 3 mLs. I've got a little bit of a bubble in here, so I'm going to try to get rid of that here. Sometimes if you just push it hard into the, there we go, that got it. Okay, so now I've got my 3 mLs. So I'm right at my 3 ml mark. Okay, this is not sharp, it's micro pen. Some micro pens are though. There's some of them that are needles, so then don't recap it if it's a sharp. This is the one. So next up, we're going to prepare to go into our patient room. Supplies that we need are going to be our alcohol swabs to administer. We're going to need a saline flush for before and a saline flush for after we give the medication. After you've pulled up your medication, like I just did, label that syringe. You always, always, always label syringe. Don't carry around syringes that don't have labels on them. So at the patient's bedside, I'm going to push this back down towards my patient's IV site. Again, assessing that site. If they've got primary fluids going, as this one does, then you will choose the port that is closest to your patient to give the IV push medication. If you are not hooked up to, and there's not IV fluids going, then you'll just go directly into that port there, okay? So we're gonna go through this closest port to the patient. So we've selected that port that's closest to the patient. Close off this IV line. We're gonna pause it if it's on a pump and close it because we don't want what we're giving in here to back flush up. So first things first, we're going to clean our site. Okay. We're then going to cleanly use our syringe, our saline flush, attach it. We're going to flush that. We want to clear that line of all the medication that's in there. I'm not going to clear it because of this mannequin, but you're going to flush with that. If you are going directly into this hub, you don't need to use quite as much. You could use like 5 cc's versus the whole 10. Okay, so we have flushed. We're going to clean. Got our medication. So we're going to connect. Administer over whatever is prescribed. I suggest you look at a clock because if there is something that you are given over 2 or 3 minutes, 2 or 3 minutes is a lot longer than what you think. I typically, what I'll do, like this is 3 mLs. If I'm administering that over 3 minutes, then I'll watch the clock and make sure I'm just administering 1 ml a minute. So I kind of split up my volume and think about over how many minutes I want to give it. So do keep an eye on the clock because I promise you when you are just slowly giving a medication over 5 minutes, that 5 minutes is a lot longer than what you think it is. So take your time and be accurate because you will hurt your patient if you are not. Next up, so I've given the medication. I'm going to clean. And if this hub hasn't touched anything, if it's sterile, if it's clean, and you haven't touched anything, then it's staying clean. But just be on the safe side, and then we'll clean it again, and then we'll flush again. So flush, med, flush. If you're given multiple medications, it's flush, med, flush, med, flush, med, flush. Start with flush, end with flush. Give a flush between every IV push medication. Okay, and that's it for IV push medication.
Okay, so let's talk about keeping our patients safe while administering IV medications. Excuse me. First up, as I said, always, always, always check compatibility. Always, always, always follow medication-specific precautions. Complications when administering IV fluids and IV therapy at the IV site. And we're going to look at each of these separately. Is going to be infiltration when, sorry, my computer's being weird today. So infiltration when you have fluid going into the tissue around it. Phlebitis is going to be, remember, itis is inflammation, so it's going to be inflammation of the vein. Thrombophlebitis is going to be inflammation of the vein caused by a blood clot there. Extravasation is going to be infiltration, but with a medication that is a vesicant that is going to be harmful to the tissue that is outside of the vasculature. So it's going to be infiltration. That extravasation is going to be infiltration with a vesicant medication. So vesicant drugs, we have a big list over here, all are going to cause damage to the tissue outside of the vasculature. Where if it's, say, normal saline, it's just going to swell up, but we'll look at that in a minute. But if you look at this list, you're going to see a ton of things that you probably see given. So lots of antibiotics and things are going to be on this list. Here's vancomycin, it's a big one, doxycycline, lots of things over here. Potassium. And then fluid volume overload, which we talked about briefly, but we will talk about again. So I'm going to go ahead and we'll go through each of these separately. So first up, we have infiltration. So that is going to occur when fluid infuses into the tissues around the vein with an IV. It sometimes happens if the catheter slips out of the vein, if it goes through the vein wall, or if there's just damage to the vein at some point. And so the fluid is going outside of the vein. So what you'll see is going to be, what you'll assess and see in the patient is the site will be swollen, edematous. Usually it's cool to the touch because it's got that fluid in it, and so it's going to be cool to the touch because that fluid is less than your body's temperature. So it is going to be cool to the touch, and then sometimes leaking around the site. First thing to do if you suspect infusion is going to be to stop the IV infusion. You see it, you suspect infiltration, stop the IV infusion. You can remember, if you're doing continuous IV therapy, you want to be checking that IV every 1 to 2 hours. So you'll need to restart a new IV. It's going to have to be proximal to the infiltration site, because if you had a, hold on, I'm trying to get my pen to work. Okay. If you had an IV site right here and it infiltrated and you started an IV right here, it's going to be going back up this vein. So that infiltration is going to continue. So you need to do it more proximal. Your IV starts need to be more proximal. Your restart to your previous infiltrated site. And other than that, you'll monitor that site, elevate it, and restart IV therapy in a different site. Next up, we have phlebitis. So phlebitis is redness, swelling, and heat related to local inflammation at that vein. So there's a local inflammatory response there at that vein. So treatment for that is going to be discontinuing the IV fluids again. Stop the IV fluids, first thing. Then you can apply a warm compress, you can elevate that extremity, and then restart your IV therapy in the opposite extremity if you can. If you can't, then you'll just like with the infiltration, you need to start proximal, or proximal to your patient. So you need to make sure you're documenting accordingly, following all your facility's policy on documentation and notification. So you may be tracking adverse events, and you should notify your physician in case they want to culture the site, because remember, inflammation can be sparked by infection. So they may want to culture that site. It can be from infection, but it can also be from the mechanical trauma, because remember, it's an inflammatory response. So it could be from the trauma of the needle or the catheter. It could be from the chemical trauma from the solution that's going in. If you've listened to potassium already, then you know that potassium can burn going in. So it can cause a phlebitis because it's an irritant. So what you'll see is, again, local acute tenderness, redness, warmth. And when I say edema, the edema that you're seeing is relative to the inflammatory process. It's not the same as the edema that you see with infiltration. The edema with infiltration is that fluid has leaked out into the tissue. With phlebitis, you're going to have localized edema from that inflammatory process. Okay. Next up, we have thrombophlebitis. So thrombophlebitis is going to be a phlebitis related to a thrombosis in the vein. So it may be superficial or deep. Most catheters are located in those upper extremities. When you put one in the lower extremity, it's going to be more at risk for a thrombophlebitis because of perfusion in the lower extremities just isn't as good as it is in the upper extremities. So we need to be on the lookout for these, for clots there at the vein. So both peripheral IV lines and PICC lines, or peripherally inserted central catheters, pose risk for clots to form around them because they're foreign to your body. So that trauma could cause a clot to form. So if you suspect thrombophlebitis, first thing, just like with the others, immediately stop the infusion. You can apply a warm compress as ordered by your healthcare provider, and then the IV would need to be restarted in another location. With thrombophlebitis, make sure that you do not rub or massage the affected area, because it is, you could dislodge that clot and cause a pulmonary embolism. So when you're assessing the difference for when you're assessing and you see phlebitis versus thrombophlebitis, is you're going to see that inflammatory process be a little bit more spread out at the site, where with thrombophlebitis, if it's regular phlebitis, inflammation of the vein, it's going to be following that vein. With phlebitis, that inflammatory process is going to be following the vein. With thrombophlebitis, you'll typically see that redness is pretty localized right at the site there. And then last up, we have extravasation. So with extravasation, you've had an infiltration of a vesicant, an agent that's going to be damaging to the tissue outside of the vasculature. So you saw that long list, and then there's also things like chemotherapy are also going to be vesicants there. So treatment is going to depend on the medication. So I'm not going to get too specific. Some medications have treatments that you could actually inject into the skin or into that vein, into the line, where it would then get absorbed out into the tissue just like the medication did, and can counteract it. But it's going to be specific. So what you need to know is, are the medication you're administering, is it a vesicant? If it is, then you need to be watching that IV site even that more closely while that medication is running. It's really going to be about prevention with extravasation, monitoring very, very closely when you're administering a vesicant. Also, if a patient is getting vesicant medications regularly, they may want to put in a central IV line so that you don't have this issue of infiltration of that peripheral IV site. If extravasation happens, it will cause inflammation and can lead to tissue damage and possibly necrosis of those tendons, muscles, nerves, and blood vessels around there. So you may end up with severe, severe injuries. So it's really about prevention and knowing what you are administering. And that is going to do it for IV therapy. If you have questions, please email me or put them into your discussion forum for Unit 4 in 117. You will also have an IV lab. So please let me know if you have any questions.